welcome to the Trinity Health IHA Medical Group Wednesday Wellness Series. Thank you so much for joining us this evening as we recognize Breast Cancer Awareness Month. So our presenting providers tonight, we actually have three of them for you this evening, and they're going to discuss recovery after breast cancer. So our first presenter is Dr. Breslin. She's a board certified surgeon who focuses on breast surgical oncology, and she practices in Ann Arbor and Brighton. Our second presenter will be Farid Nossoni, a plastic surgeon with a clinical interest in breast cancer reconstruction, and he practices in Ann Arbor, Brighton, and Livonia. And our final presenter of the evening will be Lisa McDowell, a registered dietitian nutritionist and lifestyle medicine practitioner practicing in Ann Arbor at Trinity Health Ann Arbor Hospital. So thank all three of you for being here tonight. And Dr. Breslin, would you like to kick us off?
Certainly. Thank you so much, Allison. I'm really glad to be presenting tonight, and especially glad that I'm presenting with Dr. Nossoni and with Lisa. They are great partners in our cancer program and really help us to provide comprehensive cancer care and aftercare for our patients. So the title of this talk is a little bit loose, and I thought that I would talk about some of the issues related to recovery after breast cancer treatment. I'm going to give a brief overview of some breast cancer statistics to kind of give everyone an idea of the scope of breast cancer here in the United States and in Michigan, and then go on to some of the different treatment modalities and side effects. But the type of recovery that I focus on with my patients is really related to exercise. And then I refer my patients to Lisa or one of her colleagues for nutritional management, and to Dr. Nossoni to talk about reconstructive options to help with some of the physical side effects of breast cancer surgery. So as many people probably know, the risk of breast cancer increases as people get older. And this slide here describes the breast cancer rate, which is the number of new diagnoses by age. And so as you can see on this graphic, the highest number of diagnoses occurs in women who are in their 70s, and it sort of tails off when you get into the upper 70s and 80s. And we think that that is because there are lower screening rates for women who are in their upper 70s and 80s, and other competing causes of mortality or other things that women die of or are diagnosed with at those age ranges. Interestingly, though, the median age, which is half of the patients are diagnosed, is the median age of diagnosis is 62. What that means is that half of the patients are under 62 and half of the patients are over 62. And I think that that's an important point to make, because that means that half of our patients, over half of our patients who are diagnosed with breast cancer are really in the prime of life for work and other responsibilities of life. And so it's really important to be able to get them back to full function as soon as possible so that they can continue living a full and active life. Here in the United States, there are over 280,000 cases of new breast cancer diagnosed in women, and 51,000 new cases of ductal carcinoma in situ in women. There are also breast cancer cases diagnosed in men. About 1% of new breast cancer diagnoses occur in men. And I'll just take a moment to point out the difference between invasive breast cancer and ductal carcinoma in situ. Ductal carcinoma in situ, or stage 0 breast cancer, is a precancerous condition where the tumor is confined to the milk duct. And what that means is that ductal carcinoma in situ can't spread, but we still use some of the same treatment modalities for ductal carcinoma in situ as we do for invasive breast cancer, which has extended beyond the basement membrane or the covering of the milk duct and has the potential to spread to other organs. And so that difference really informs our treatment recommendations for women with these two types of cancer. The important thing to remember is that most breast cancer is diagnosed at an early stage. And when you look at across the board, including both ductal carcinoma in situ and invasive cancer, there's about a 90% relative survival rate at 5 years. And so that's really encouraging information. That also leaves us with a lot of women who have a history of breast cancer. And this includes both women who are cancer-free and those who are living with active cancer or undergoing cancer treatment. But that includes about over 400 or 4 million women in the United States at any one time. So there's a lot of women living with potential treatment side effects, and also men with treatment side effects. Here in Michigan, we estimate that in 2022, this is data from the American Cancer Society, there will be about 8,900 women diagnosed with breast cancer, and about 1,400 women will die of breast cancer here in Michigan. So this is a significant condition here in our state and deserves our attention. Most breast cancer is diagnosed through screening mammography. The picture on your right is a single view from a screening mammogram depicting the breast here and then the muscle behind it. If you compare that to the actual sort of three-dimensional anatomy of the breast is made up mostly of fatty tissue covered with skin. And then underneath and intermixed with the fatty tissue is glandular tissue. And you can kind of see that here would be the glandular and fibrous tissue here. And then here, the black or darker colors represent the fatty tissue. And I'm not trying to turn anybody into a radiologist, but it's often really interesting to note sort of which structures in the breast lead to which findings on a mammogram. So breast cancer treatment is multidisciplinary, and for many patients, it includes a combination of surgery, radiation therapy, medical treatments, which can include either chemotherapy or hormonal therapy or a combination of both, and supportive care. Our supportive care modalities include psychosocial, psychotherapy, financial counseling, and a variety of other therapies and nutritional counseling. Many of our patients who are recently diagnosed with breast cancer ask us, well, how did I get this? And what can I do to prevent developing breast cancer again? And should I eat certain foods? And so that's a situation where I might refer one of my patients to meet with Lisa or one of her colleagues to have a one-on-one counseling session about the best nutritional support that they can achieve during their breast cancer treatment and afterwards. The focus of breast cancer treatment is to really personalize the treatment recommendations to the individual patient and their situation, their stage of disease, and their extent of cancer. Over the past 20 to 30 years, there's been a focus on de-escalation of therapy. And what that means is that when breast cancer surgery or breast cancer treatment first began, it was really focused on aggressive surgery. There was a procedure called the radical mastectomy, which removed, I'll go back here, the breast, the skin, the muscle behind it, and was a very aggressive procedure that left women with many side effects and long-term disability. We have now demonstrated that less aggressive surgery, such as breast-conserving surgery or less aggressive mastectomy, is as good and leaves people with fewer long-term side effects. We also have targeted therapies such as immunotherapies, which are administered by our medical oncologists for some subsets of women based on their specific tumor biology. Now, breast cancer treatment is fairly intensive for 3 to 12 months, I would say. And many patients, although the treatment is hard, feel very supported during that treatment. And then they wonder at the end, of that intensive treatment period. Well, what do I do? I've been a patient every day or multiple times a week or multiple times a month for the last year. I feel a little bit alone. I'm not really sure what to do. And so that's our job as people near the end of treatment, to help them transition back to their regular lives. And that's what our focus is on. Some patients undergo extended therapies with what we call endocrine therapy. These are treatments that are designed to block action of estrogen or block the formation of estrogen, and are appropriate for many women with breast cancer. But that can last from between 5 and 10 years. And so that's a really long time for patients to be under active treatment. And those individuals need a lot of support from their medical oncologist. Many people tolerate these treatments without many side effects at all, but some people have significant side effects. These treatments, surgery, medical therapy, and radiation therapy, have both short and long-term effects. The short-term effects are the ones that we often associate with cancer treatment. And those include hair loss and other sort of short-term physical changes. And the American Cancer Society has wonderful programs such as Look Good, Feel Better, which help women and men with cancer cope with the sort of cosmetic changes associated with chemotherapy. And that's a wonderful program that really helps people stay comfortable in their life and in other social, in their job and in social situations. Surgery for breast cancer, as I mentioned, is much less intensive than it was in the past. And most women currently who undergo breast cancer treatment have a lumpectomy or breast conserving surgery. That procedure involves removing the tumor with a rim of normal tissue around it, and is usually followed by radiation therapy. For women who aren't a candidate for a lumpectomy because the tumor is too large, or they choose to have a mastectomy is done to remove the tumor, but we are able to save most of the skin, and oftentimes we're able to save the nipple. During a mastectomy, and during a lumpectomy, we often take some lymph nodes, and there can be side effects such as abnormal sensation under the arm, and in some cases lymphedema or arm swelling. So the late effects of breast cancer treatment are many, and they are important because if so many people survive breast cancer, that means there are a lot of patients dealing with side effects such as osteoporosis, altered body image, early menopause, infertility, sexual dysfunction, emotional distress. People are worried about recurrence. They often tell me that they feel afraid to even come in to see us in the office because they're afraid of what we're going to say. They're afraid that maybe we're going to tell them that their cancer has recurred. Many people live with joint and muscle pain. It's difficult sometimes to differentiate this joint and muscle pain from the joint and muscle pain of just everyday life and getting older. But there are treatments for these side effects. Neuropathy is a common side effect of chemotherapy. Pain, either surgical pain or pain related to neuropathy, can also occur. And a very common and distressing side effect of breast cancer treatment is weight gain. And so we often turn to our nutrition colleagues to talk to our patients about getting back to a healthy diet and lifestyle, because when our friends are sick or having surgery, our tendency is to try to kill them with casseroles, bring them rich, nourishing food, but it's often not very easy to maintain a healthy diet when everybody's bringing you all these treats and kind of calorie-packed foods. So how do we manage the late effects of breast cancer treatment? We focus on physical effects, social, emotional effects, and we also partner with our primary care providers and gynecologists on prevention and screening. So I think that the most important intervention that we can do to help people improve physical function after breast cancer treatment is to encourage them and help them get back to exercise. Exercise has many benefits, including increased muscular strength, decreased body fat percentage, increased VO2, which is a measure of endurance, and many studies demonstrate an improved quality of life. So what counts as exercise? Not everybody is a runner. Not everybody is even a regular walker. But other examples would include swimming, even water aerobics. Group exercise classes are a great way to get motivated to stay moving for 45 minutes to an hour, and usually they're pretty fun. Yoga, yard work. Some people even recommend housework, but I don't like that as a recommendation for exercise because I kind of am unhappy when I do housework. So I'm not going to recommend that as a form of exercise for anybody. But really the important message is that it's movement, and finding a way to enjoy movement will help with many of the side effects that you see here. Joint and muscle pain is improved by strengthening the muscles. And it's hard to get people to move when they're already hurting, but the stronger your muscles are, the better you are in terms of pain. It improves emotional distress. It helps with weight gain and can help with lymphedema, as well as body image. And regular exercise helps maintain bone health. So how can we help people start or resume exercise? There are a number of programs here in Ann Arbor that are available for the community. One is Live Strong Group Exercise. This is offered through the YMCA, and they accept cohorts or groups of patients to do a 12-week exercise program. And it's both exercise and support. One of my patients told me that she really appreciated this program because not only did they help her get back into exercise, but they welcomed her to come even when she wasn't feeling like exercise. They told her, we just want to see you this week. It doesn't matter if you exercise. And so it provides a safe space to come and try to exercise, but also just be with other people who may have the same issues. We partner with the cancer support community, and they have a number of both online exercise classes. They also provide emotional support. And so they're a wonderful resource as well. There are also medical recovery programs through physical therapy centers or health centers and recreational centers. And these are a great way to have a guided reintroduction to physical exercise. So there's a lot of ways to get fit. And there are cycling programs such as bicycle rides through the American Cancer Society. The Avon Foundation does the 3-day walk where people walk, I think, 40 miles a day. My friend Judy Tijo is a breast surgeon in Milwaukee, Wisconsin, and she actually got funding to support breast cancer survivors to do triathlon training. And they trained as a group and participated in a triathlon. There's women's rowing teams, and you can see they're all wearing their little pink shirts, really focusing on coming back to fitness or starting a fit lifestyle after breast cancer diagnosis. And my favorite is horseback riding. And so I think there are a number of what we call pink ribbon events where people either ride to raise awareness or actually ride for fitness. And all of these exercise programs and modalities have the same benefits in terms of muscular strength and improved quality of life. So I encourage all of my patients to find some form of exercise that they enjoy or think that they might try to enjoy. For social emotional recovery, again, I mentioned the support groups through the cancer support community, both individual and group support. The American Cancer Society has a number of support services and programs. We refer patients for individual psychotherapy to address not only anxiety and depression, but specifically fear of recurrence. And it's also important for our patients to regain or maintain social connection with friends and family. People can often become isolated during the intensive period of cancer treatment. They may not feel like being in public or worry about being in public because of side effects of cancer treatment and or changes in their appearance. And so we have to kind of help them get back their social confidence to start engaging in regular social activities again. And lastly, I just want to focus on prevention and screening. Once a patient is done with cancer treatment, they are still a primary care patient, right? We're trying to pay attention to their whole health. And so we need to remember that while breast cancer has excellent survival, and there are a lot of women who have been diagnosed and treated for breast cancer, there are other causes of morbidity and mortality, meaning disability and death. And specifically, I want to call out heart disease, lower respiratory diseases such as emphysema and bronchitis, and stroke. These are conditions that are preventable through lifestyle changes. And so it's a very high priority for us to talk to our patients about preventing heart disease and stroke by managing blood pressure and cholesterol, diet and dietary modification by increasing fruit and vegetable consumption, and by exercise. We also talk to our patients about colon cancer screening, cervical cancer screening, and skin cancer screening, because these are the other common causes of cancer in our patient population. We have an upcoming event at Trinity Health Ann Arbor. It's an evening of wellness, and we will have our oncology certified dietitians there. We'll be talking about screening opportunities, a real amazing gem that we have at Trinity Health Ann Arbor, which is the farm, which people can buy a membership in the farm and get fresh fruits and vegetables. And we have support for some of our patients who may not be able to afford a farm share. They also teach some classes, and then there'll be some offerings through the cancer support community in Move Ann Arbor. So I encourage anybody who is able to attend. It's on October 26th in the lobby of the Cancer Center here in Ann Arbor. And so that's all I have. I'll be passing it over to Dr. Nossoni, who is one of our wonderful plastic surgeons at IHA, and I will stop sharing my screen so that he can take over.
Good evening, everyone. I'm Farid Nossoni. I'm one of the plastic and reconstructive surgeons here with IHA Medical Group in Ann Arbor, Livonia, and Brighton. Thank you, Dr. Breslin, for inviting me, and thank you for the wonderful presentation. So what I would like to focus on during my portion of this talk is more of a long-term recovery from breast cancer, and how breast reconstruction and how plastic surgeons could play a small role in helping putting patients in a path for a healthy and better lifestyle, as Dr. Breslin discussed. So kind of overview of what I'm going to briefly talk about. We'll talk briefly, we'll mention a little bit of a history of breast reconstruction. Kind of what does it mean to have breast reconstruction? What do we look at, the interactions in the anatomy of body and the long-term effect of that? Some of the surgical options that we have, we will briefly discuss. And then we'll talk about patients who have lumpectomies that may not need reconstruction, or patients who don't want to have any reconstruction. Are there any surgical options that could help those patients potentially put them in a path for better long-term recovery? And now I'll briefly talk about lymphedema and some of the medical and surgical options that we have for treatment of lymphedema, as well as some of the prophylactic things that we can do to potentially prevent it from happening. So interesting that Dr. Breslin mentioned radical mastectomy, and it really has been a long journey from 1899 when kind of father of modern surgery, Dr. William Halsted, performed that radical mastectomy. And it really lasted probably longer than it should. It was a surgery that was performed for many, many years. But over the last, I would say 40, 50 years, we really have started working on the evolution and development of the breast implants. So the first breast implant was developed in the 1960s. Actually, Dow Chemical here in Michigan was one of the first companies that came up with the silicone implants. And Dr. Stray in Detroit was one of the first physicians who performed implant-based breast surgery. The concept of tissue expanders and promoting growth of the skin to be able to place an implant under that was started in the 80s. And the microsurgical techniques that we use now for some of the autologous breast reconstruction started in the 80s and 90s. So as you can see, we have continued to evolve and develop to make a more aesthetic and more functional reconstruction for our patients over the last 40, 50 years. And we continue to evolve in that aspect to try to do a better job. So when you think of breast reconstruction in the frame of recovery and the long-term recovery of a patient, is our goal by definition is to create a natural look and natural feel and balance in closing. I want to point out that breast reconstruction is a choice. And when patients face the diagnosis of breast cancer, sometimes breast reconstruction is something that they don't want to deal with at that time. They want to just free themselves from the disease. But you always have different options that are available from a reconstruction immediately after your mastectomy versus having a delayed procedure done. And the option is always with patient, and that's probably one of the best things that happened with the Women's Act of 1998. It provided that option for patients to have a long-term treatment and long-term care whenever they choose to have it. So when we are doing a breast reconstruction, and this is kind of like the anatomical part of my presentation, which I'm going to briefly go over. But I think it's important because it's very important to understand this is a very personalized treatment. There is no one way of doing breast reconstruction. We look at each patient, their lifestyle, their goal for the future, and what they want to do down the road, and we make a decision based on that. But when you're looking at the breast and think of breast reconstruction, there are three aspects and three principles to look at. One is the breast footprint. That's kind of like where the breast is, the breast conus, and the skin envelope that covers it. And the most important aspect of breast reconstruction is the interactions between these three factors that provide better reconstruction. So breast footprint is really the outline that breast makes on the chest wall. It's like the foundation of where the breast stands. The footprint forms the foundation of the 3D structure that we talk about. And chest wall is very stable, but it's also very unique to individual patients. The breast conus refers to the 3D shape of the projection and the volume of the tissue or the implant that is used on top of the anterior chest. Very specific volume distribution, yet is very different for individual women. You can go to medical conferences, and I was in one in Atlanta last year, and they spent a solid 20 minutes discussing whether the upper to lower ratio in the breast is 50-50 or 45-55. And they spend a lot of time talking about it. But the key to remember is that each individual patient has a different breast conus that is individual, that is unique to them. And finally, is the skin envelope. So skin functions as this well-fitting bra in a sense, holds the tissue in a correct position. The redundancy, as we know, can lead to odd-shaped breasts and breast ptosis. And lack of a stent quality and quantity could lead to wound healing issues and a flat look. So when you think of breast reconstruction, and when we see a patient to have a discussion with them about their goal of what they want to do, we look at the interactions between the footprint, the conus, and the envelope to be able to create a desirable functional outcome for the patient that could last them many, many years. And the interactions between these three factors makes a huge difference in reconstruction of the breast. So the methods of breast reconstruction is also unique. And I'm going to briefly talk about this slide. The most common form of breast reconstruction in the United States remains the implant-based reconstruction. The implants are silicone-made or saline-made. They have really changed over the years to become better, more stable, and more unique. The surgery can be done in 1 or 2 stages, depending on the mastectomy that is needed. So one of the things that we do, we spend a lot of time interacting and talking to our surgical oncologist colleagues like Dr. Breslin to make sure the patient gets the appropriate cancer surgery and also provides us with the chance to provide the best reconstruction option for the patient. All of us, the surgical oncologists, the plastic surgeons, also work very closely with patients to look at their lifestyle and some of the postoperative treatments that they need in order for us to provide a unique and individualized care for patients. So and I will briefly talk about some of the methods about the position of implants in a little bit, but each patient would require a different approach, and that's what we kind of look at for these for our patients. Autologous tissue reconstruction is done in a pedicle fashion where the blood supply is kind of connected to the tissue and we just move that tissue around. Or it could be done in a microsurgical option, like a deep flap, that we move the tissue with the vasculature and we perform the connection of the tissue to the breast to create the breast mount that way. Or there is a combination of the autologous and tissue-based reconstruction. These are some of the examples of what we can do, for example, with the implant-based reconstruction, some of the options that we have where we position the implant in with respect to the muscle, whether we place it under the muscle, over the muscle. It all depends on a long-term plan for the patient and also the individual patient for each patient. So if we have a patient who's, for example, a yoga instructor, we will not put the implant under the muscle, would create some functional and aesthetic deformity for them down the road. So we are very cognizant of each patient and what is best for them, and we can offer the best surgery that provides, as we discussed, the whole point of this conversation is that long-term good and healthy recovery for patients. So with regard to patients who lose the nipple, so we have a nipple sparing, we have a skin sparing mastectomy, but the nipple is excised during the surgical intervention. That's one of the things that patients ask us a lot down the road in 3-4 months after the reconstruction is done, and they start to feel better, but now they want to have that feel when they look at themselves in the mirror to have that nipple areola complex. There are many options surgically to do that. We have local flaps that can be done, skin grafting to create nipple areola complex, but I also want to point out 3D tattooing that has become more and more popular and better over the last few years. Honestly, some of the pictures that I could find, and I didn't want to post a picture of a particular patient that online that I didn't have a permission, but I would recommend you just Googling 3D tattooing for nipple areolar complex reconstruction. It really has changed the game. There's some that you look at and you honestly don't even know if it is real or not. So they've done a really good job, and more centers start to kind of offer that. So that has really been a game changer when it comes to nipple areolar reconstructions for patients that we are not able to save the nipple. So what if you're having a lumpectomy and all this conversation that I had about the breast reconstruction doesn't apply to you? As you know, most of the patients with breast cancer just need a lumpectomy right now. So one of the things that to me has been a life changer for a lot of patients, and as a surgery that I personally like a lot, is, and I think you have a long-term effect when we're talking about healthy lifestyle down the road. This is one of the surgeries that could really be a life-altering surgery, is what we call oncoplastic breast reduction. So oncoplastic breast reduction is in patients who need a lumpectomy. And as long as they meet the criteria that the mass is in a position that can be excised, and then the plastic surgeon would come in at that time, and based on the tissue that is left, will perform a breast reduction. And as you can ask the patients who have done a breast reduction, that's probably the most satisfying surgery that we do as plastic surgeons for our patients. Is truly life-altering with back pain, shoulder aches. It really solves a lot of problems for our patients. And I don't know, even patients who have minor wound-related complications, they tend to be very happy that they did this procedure of breast reduction. So this is a case that we can use lumpectomy as, in a way, for lack of a better term, as opportunity to perform oncoplastic breast reduction to make sure the patient down the road have a better look and a better feel, and is able, as we discussed, as Dr. Breslin very nicely discussed, make those healthy, better life choices and be more comfortable to do that. So I think that's a very powerful surgery, is becoming more and more popular, and it's one of my personal favorite procedures to do. And what if you don't want to have any breast reconstruction? And that's a very fair point. A lot of patients, breast reconstruction is a lengthy process. It requires multiple surgeries. Even the one-stage procedure is really not a one-stage procedure. Most patients will require some sort of a revisional procedure down the road. So some patients just don't want to have any breast reconstruction done. Is there anything we can do to provide a more aesthetic, more better feeling for the patients to be able to have a long-term recovery? And one of the things that have come up recently in the last few years is what we call the aesthetic flap closure. So aesthetic flap closure, in a way, is the gold standard for going flat. And it's a post-mastectomy chest wall reconstruction. So for the patients who have a mastectomy and they don't want to have a reconstruction, in an immediate or delayed fashion, plastic surgeons or breast surgeons would get involved and perform these changes and tissue rearrangements to make sure you have a very flat chest that is aesthetically appealing to the patients. When you perform a mastectomy, sometimes there's some excess tissues and the skin, especially in the axilla and in the medial aspect. We call them dog ears. This procedure will kind of make sure we remove all of that and we provide a nice flat chest. Sometimes the lumps and bumps in the mastectomy side, those can be trimmed. Tissue rearrangement can be done. Fat grafting could be done. And it really is a powerful surgery to perform, and for the patients who don't want to have any sort of reconstruction, but they want to have a flat chest for years to come without dealing with these excess tissues laterally or medially in particularly. And as I said, it can be done at the time of surgery, or more commonly in a delayed fashion. And then these are some of the examples of what we can do to provide that shape that the patients want based on the mastectomy incision that they had, and to provide that nice and flat shape for them. And finally, I'm going to briefly talk about lymphedema and lymphovenous bypass. Lymphedema is, by definition, is accumulation of fluid in upper extremity, usually after axillary lymph node dissection. So a substantial, one of the good news about lymphedema is, as Dr. Breslin mentioned, that as the more and more patients getting sentinel lymph node biopsy and less axillary lymph node dissections, the number of patients with lymphedema is going down significantly over the last 10 years or so. But patients who do require axillary lymph node dissection, different studies suggest different numbers, around 20–30% could potentially develop lymphedema. And this could cause pain and swelling and discomfort, and again, prevent patients from doing what it is that they want to do, to go out, exercise, be with their family. Just it could be a little life-altering in some cases. So there are non-surgical treatment options that we work here with our physical and occupational therapists through the breast clinic, and they do a fantastic job helping these patients. And then there are surgical options that are now being offered to help with these procedures. We can also offer some of these surgical options as a prophylactically for patients who are getting axillary lymph node dissection anyway. So it can be used as a treatment option, and it could also use as a preventive measure. So lymphovenous bypass is a microsurgical and microscopic procedure to essentially use a lymphatic vessel and connect it to a vein in the same area to bypass the blockage. And this is done under the microscope, and it's one of those surgeries that I would say still is in infancy. There are more and more research that is coming out to kind of show us what's the best option to do it. So it's a very, very active area of studies and research in plastic surgery, but it could potentially be a powerful procedure to prevent patients from potentially developing lymphedema. As I mentioned, it can be done prophylactically at the time of the lymph node dissection, or could be done as a treatment method. But as I said, it is in its infancy, and monitoring it and studying it is a little difficult. And there are so many different techniques that are offered, and some are very good, some are not as good. So it's kind of something that is, I would say, is evolving, but it's definitely a very fascinating, exciting area in plastic surgery. So these were some of the procedures and some of the things that we can do as plastic surgeons for our patients to promote that long-term recovery and long-term health. And I appreciate the time. I appreciate you all for being here. And I believe Lisa is taking over. So I'm gonna pass it to Lisa now. Thank you all.
My name is Lisa McDowell, and I'm the Director for Clinical Nutrition and Lifestyle Medicine. And I'm so happy to bring some of these best practices and tips your way. Lifestyle medicine is the evidence-based suggestions around how to live a healthy lifestyle, looking at stress reduction, having a plant-forward diet, getting really great quality sleep, being socially connected, having the right people supporting you, getting plenty of movement, physical activity, and then avoiding risky substances. So with that, I'd like you to just stop for a minute and think about your own habits in your whole routines for the day. What is serving you and what is helping you on your journey with healing? A lot of times, the best practices come from what we have the power over. And so if you tell yourself that you choose not to do something because you know it is not in the best interest of your recovery, it does give you the agency of control over that habit, versus if you feel like you can't, then that takes the control away from you. So sometimes just, simply reframing how you're choosing your lifestyle is really, really helpful. After developing our lifestyle medicine curriculum and learning about some of the practices, even just with restaurants locally, the ingredients that they're choosing are not really sometimes serving us for our health, but they're inexpensive and there to help them make a profit. And so I personally feel like I would not go to McDonald's and choose that food because of the type of ingredients that are selected. And so I give myself that agency over control that I want to do something better for my own health. So going through each pillar, I'd like you to think about your own habits, your own routines, and what do you do to recover from daily stress? We know that the experts recommend things like meditation or singing really loud. That really helps us with our vagal nerve tone in the recovery from our sympathetic, our fight and flight, to our parasympathetic, which is the rest and digest. It's called an autonomic nervous system because we really have to be mindful of shifting out of that type A, go, go, go all the time. And this is the time for you to put yourself first. And so recovering from the day's stressors, whether it's connecting with family or going outside in nature, going for a long walk, maybe doing yoga stretches or breathing or journaling at night. Sometimes just like writing down the three good things that have happened to you can really alleviate stress and can help you to see the positive. Enjoying plant-forward meals. We know that it's really challenging. If you look around in the United States, the number of people who are overweight and obese, developing heart disease and cancer, so sometimes our food system is connected to these problems, and obesity is a real issue. So we're looking at how can we hardwire our own environments, what we choose to bring into our house. If we do go to a restaurant, how do we manage that? And what are some of the best practices around, a plant-forward diet? I like to think of myself as a superfood hunter, where I'm looking in all of my environments, working at the hospital, or if I'm going out with friends, how can I find the super micronutrients? And when I say micronutrients, I'm talking about the vitamins, the minerals, the phytochemicals. These are just profoundly impactful for the different pathways in our body that create inflammation. So we want to upregulate some foods for certain pathways. There's one called NRF2, and certain foods like turmeric and ginger are really helpful for that. And we want to downregulate some inflammatory pathways like NFKB. And again, we're looking at things like ground flax seeds and green tea, even a little bit of dark chocolate. Some of these very micronutrient dense foods really are like medicine to us. So eating the rainbow, there's a physician named Dr. Will Bulsiewicz who wrote a cookbook called Fiber Fueled Cookbook. And he challenges everybody to try to get 40 different plants in a week, in doing this as a family activity. where maybe you just keep a log, because we know that having so many different contributions of these vitamins, minerals, and phytochemicals is incredibly protective for us. The macronutrients being carbohydrate, protein, and fat also are important. And so really taking a look at trying to do more whole foods with no processing or minimal processing is the most healthy thing that you can do. Looking at your sleep routine, I think this is an area, unfortunately, that everybody can probably do a better job with. The statistics across the nation are quite poor. We really struggle with getting a good night's sleep. And so when you think about your own routines, we look to the experts like Dr. Matthew Walker and Dr. Andrew Huberman for some of their protocols, which are just fantastic. We know that getting bright light exposure in the morning is one of the best things that you can do. That helps to reset your circadian rhythm just for 10 minutes in the morning. And then making sure you're avoiding the bright lights at night and instead maybe settling in with a book or playing cards, avoiding stressful or anxiety producing movies or video games before bed, and then making sure that your bedroom is like a cold, dark cave, no lights, just making yourself as comfortable as possible and developing habits around your nighttime routine. It could be, sitting with a cup of hot chamomile tea. And while the research doesn't show that it's the chamomile per se, it might just be the wind down routine. The suggestions of 8 hours of sleep are really important because when we're closer to waking up, that's when we're getting more of our REM sleep usually. So we're trying to optimize deep sleep and REM sleep. It's important for cleansing out your brain while you're asleep, so we're not accumulating any of the sticky tau proteins, any amyloid. We also know that when we sleep, we consolidate memories, and the experts say that we recover physically from our exercise with deep sleep, and we recover emotionally from REM sleep. So looking at some of the apps that are out there, and there's so many that are free, some really great ones with breathing techniques. They've shown that just 6 box breaths, breathing in for 4, holding it for 4, exhaling for 4 seconds, and then holding it for 4 seconds. Doing 6 cycles of that can switch you from your sympathetic fight or flight to your parasympathetic nervous system, the rest and digest. So just 6 simple box breathing sets is so helpful. Listening to guided meditations can help change your brain waves and set you up for sleep as well. Watching out for all of the social media addictions. I know so many people are looking for likes on Facebook or Instagram, and really just maybe using that more minimally for learning great recipes. That's what I like to use that for. And then looking at your tribe, who is on your healing journey with you? They say that we're the average of the 5 people we spend the most time with. And so if you're looking at changing habits, it's great to connect with other people who have similar interests. I like to be outside, hands in the dirt, gardening. I have 2 dogs myself who enjoy going for a walk. And, the best practices are putting yourself first, making sure that you have time in your day to relax, de-stress, move, and socially connect. When you do exercise with a partner, there's actually a synergistic gain by moving and laughing and being with other people. Social motion boosts the connection and the performance. So just getting out with friends. Avoiding risky substances. This is both alcohol, drugs, marijuana, but also it includes things like the salt, sugar, and fat. And while I mentioned the fast food industry has really tried to program us to become addicted, if you think about taking a bag of Doritos or potato chips, you keep finding yourself going back in the bag, and it's shocking how much you can eat. Well, that's our body craving the nutrients which are not found in the processed food. And that's the reason we can overeat so much. And so just really being aware of where those weak spots are, where you're not so mindful of the volume that you're eating. I like to say, watch out for the wolf in sheep's clothing. There's a lot of different things out there that are shockingly high in calories and fat. You would think getting a ranch salad would be good for you, but this is an example on the right there, 2150 calories, 137 grams of fat. I like to peruse menus before I go out to see, what looks good, what will help my health goals. Every single bite that we take is a vote toward a healthier future. So just supporting all of your pillars, the physical activity, the being outside in nature, connecting with others, and making sure that you are putting yourself first. And this is a handout from the Lifestyle Medicine organization. You can see American College there. That's their website. They have so many great resources that are free PDFs that talk about all of the best practices of the 6 pillars. And they're just excellent handouts. So you will have access to these slides. And with that, I will share it back. Thank you.
Excellent. Thank you so much, Lisa. And we can share the link that you have here in the email that we sent to follow up with everyone afterwards. So that's a great resource. I agree. Okay, so Dr. Nossoni, Dr. Breslin, and Lisa, if you would like, I'll start kind of reading the questions to you. And if you have a question, please put it in the Q&A section down at the bottom of your Zoom screen. So our first question, I think, will go to Dr. Breslin. It says, at what age can I stop mammograms? I'm 74 and had both radiation and chemo. I eat well and exercise. I've heard that breast cancer is very slow growing in our later years.
So that is a great question, and one that stimulates a lot of conversation, because our current recommendations are that for routine screening, women should continue to have mammograms or conversations with their primary care providers about having a mammogram either every year or every other year, as long as they are fit and think that that between the two of them, they feel that that individual is likely to live another 10 years. My patients in their 70s and 80s start to talk to me about discontinuing or doing mammography only on an as-needed basis for new symptoms. And so I think that if it's been a number of years since breast cancer treatment and lifestyle is otherwise healthy, it's perfectly reasonable in your 70s to consider discontinuing mammography after you talk with your primary care doctor. So that's a great question. No one ever really wants to broach that question, though, because we don't want our patients to think that we don't care. And one of the ways that we care is we offer recommendations for screening and testing, but an even better way to care is to help people decide when they can drop some things out of their medical routine. And for me, while it's difficult sometimes for me to say goodbye to a patient after 5 years of follow-up, I also think that I'm making their life a little bit simpler. I'm cutting at least one doctor out of their menu of medical care and giving them time back so that they don't have to think about making and keeping appointments.
Awesome, thank you. So the next question for Dr. Nossoni, can you state briefly how long the recovery time is for breast reduction surgery?
Usually, to kind of go back to full physical activity and kind of like a no restriction is around 6 weeks. But the recovery from the actual surgery is probably like 3 to 4 weeks. But to go back to the normal life is 6 weeks.
Okay, excellent. Okay, and Lisa, is there a recommendation for the best diet to follow after you have breast surgery?
Yes, so I liked I like the joke from Dr. Breslin about being killed with casseroles, and it's so true. We really are looking for just the simplest, basic, whole food, plant-based diets as much as possible. Being plant forward, we do have this wonderful farm that's a great resource. And for those who are interested in that, having a local box of produce with recipes every week is just such a blessing. I think the goal of looking for the superfoods, the foods that are very dense in nutrients. We joke that a blueberry is very different than a candy, and the reason being is because of those deeply pigmented compounds in the fiber that are very protective. So getting a wide variety of plant compounds, including things that are also high in protein for healing, is very important. But the best way to heal is through a healthy diet.
Excellent.
I-
And oh, Dr. Breslin.
I just wanted to also add that the American College of Lifestyle Medicine has some really wonderful recipes. I don't know if we could add those to the links. The ones that I'm thinking about, Lisa, are those Power Bowl recipes and the smoothie recipes, because it's not just one smoothie. It gives you 25 options for different smoothies or Power Bowls that you could make. And so I challenge anybody to say there's nothing on there that they would like, because there's so many different ingredients and options.
Yes.
I agree. And I think the other suggestion is to look at opportunities to add things to maybe something you're already doing in your routine. So for example, if you like oatmeal in the morning, adding some walnuts and cinnamon and berries, chia seeds, ground flax seeds, those are very protective foods, or making a chia pudding or the little energy balls. Those are fantastic ideas, and smoothies are a great way if you really don't have a strong appetite to be able to put, spinach and berries into a smoothie.
That's an excellent point. And I always kind of laugh to myself when people talk about flavors, when like there'll be a loss of flavor, which with fruits and vegetables, and it's so not true. The colors and the flavors are just, they're so good. So
Yeah.
That's a great point. And I will definitely include a link for the farm as well. We were able to get a couple boxes from the farm this year, my family and I, and it truly is, it's so fun. And you get vegetables that maybe you wouldn't necessarily buy, but then you kind of learn about them, and it kind of expands your diet a little bit. So it's
and
really
I think also just remember to look for the rainbow, the colors when
right.
you're grocery shopping, and think about how many family members you're shopping for, to make sure you're bringing in enough volume so everybody can have access.
Definitely. Excellent. Okay, Dr. Nossoni, we have another question for you. Is plastic surgery usually needed or performed during or after a lumpectomy?
Usually not. I think Dr. Breslin would be able to answer that question even better. But usually the oncoplastic reduction is the one surgery that we are involved with patients who are getting lumpectomy. There are some places that they do, like in a delayed fashion, some tissue rearrangement if there's a defect that needs to be filled, and we are available. But in vast majority of cases, plastic surgeons are not involved in lumpectomy procedures.
Dr. Breslin, did you want to add anything to that?
Nothing really to add.
Okay.
Typically, we don't have the plastic and reconstructive surgeon involved at the time of a lumpectomy, but there are situations where if we're removing a large volume of tissue, we would have them help us during that procedure. Or if a patient develops asymmetry after a combination of surgery and radiation, we may refer them to the plastic and reconstructive surgeons at that time to help improve either the shape or the symmetry.
You kind of led into the next question, which is, how is the unaffected breast dealt with if only one breast is affected by breast cancer? Is it covered by insurance to be able to operate on that breast to make sure that you have that they match? And how hard is it to match an existing breast when you're building a new one?
So not to kind of make any political statement, but one of the greatest accomplishments of President Clinton was probably the Women's Act of 1998. It was something that was very personal to him because President Clinton's mother died of breast cancer. And that law essentially that bill made it law that every procedure for breast cancer and breast cancer reconstruction and mastectomy, including symmetry procedures, are all covered by law. And so for the most part, the other unaffected side is covered. And how it is quite difficult to match a non-reconstructed breast that kind of sits up high versus a non-reconstructed natural breast. But it's possible, it's doable, but it is a difficult procedure, but we're happy to help.
Do you recommend having surgery on both breasts, even if one is not affected by cancer?
Usually the procedure is done at the end, essentially when it's all said and done and the breast is entirely reconstructed. If the patient would want a reduction or mastopexy, which is essentially a lift to kind of make him look even, we'll perform it at that time.
Gotcha. Okay, that makes sense.
And I'd just like to add, that's a pretty commonly performed procedure for our patients who may have larger breasts, particularly. If we do a reconstruction, such as a mastectomy on one side, they'll often have significant asymmetry, and nobody's really very happy with that. And so our plastic and reconstructive surgeons do a lot of what we call symmetry procedures, either to reduce or do a mastopexy on the other side. And that can really improve the quality of their physical functioning. They just feel better in clothes, feel better in their bra, feel more like exercising.
Okay, great. We have a question about dense breasts and what kind of screening should be done for a dense breast, and is there a relation of vitamin D in this case?
So dense breasts are breasts that have more of what I showed you in that mammogram, the white tissue, and that's more connective tissue. And it's hard for the radiologist to see through that connective tissue to find abnormalities. So for women with dense breasts, we have three options. One is 3D mammography or tomosynthesis. And that allows the radiologist to sort of look between and around areas of density. Another option is breast ultrasound, although whole breast ultrasound has not been utilized very extensively here in the United States, primarily because there's just a lack of time to do a complete breast ultrasound on individual patients. It takes about 45 minutes to do a whole breast ultrasound. And our aim is to screen as many people with high quality imaging as we can. And that includes a 3D mammogram. A third option, which is available, is a rapid protocol MRI. Most MRIs of the breast take about 45 minutes and is done mainly for our patients with high breast cancer risk. But the rapid protocol MRI is specifically targeted for women who have dense breasts and is an option. And this one only takes a few minutes and can be used as an adjunct to mammograms.
So you touched on this next question about a breast ultrasound. Is it a reliable version of screening?
So breast ultrasound is primarily used as part of a problem-solving exam. So a screening mammogram takes 2 pictures of each breast, and the idea is to look for abnormalities in a patient who has no symptoms. A diagnostic mammogram is a second stage mammogram or a mammogram that's done in somebody who has a symptom or an abnormality on mammogram. And then the ultrasound can be an additional modality where we will look at areas of density or masses that are found on physical exam or mammogram or even on MRI. But it's not meant as a standalone screening exam.
Okay, perfect. Thank you. So we have a question around protein powder. Do you recommend using this, especially when you're making those smoothies, or is that something you should stay away from and just let the protein come from kind of the natural sources?
So that really depends on the lifestyle and what's available in the kitchen. So if you're shopping and you have something like tofu, I know some people think that you need to stay away from soy, but you do not. Adding something like tofu into a smoothie gives you a really nice benefit. Actually, women who eat soy have a decreased chance of breast cancer recurrence. So having a glass of the soy milk or soy would be great. The protein powders are not all created equal. So when you're choosing a protein powder, I would recommend looking for one that has a third-party certification on it. There's a label called NSF. And the reason that we look for third-party certification is because dietary supplements are not regulated. And they could have banned substances, they could have heavy metal contamination, and we just want to make sure that the choices are safe. So looking for something that has been tested so that what they're claiming is inside is truly just a protein powder. It shouldn't be so complicated, but unfortunately, without regulation, you want to make sure what you're putting in is what the label states.
That's a great point. And I know so many people are so busy. So grabbing a protein powder probably would, help, but it's hard to get the right one. Actually, we do have a question specifically about soy. And she's wondering, would you recommend it for someone who had hormone positive cancer?
Yeah, I think people hear the word phytoestrogen as part of soy, but they're very high in isoflavones. And so having something like tempeh, miso soup, tofu, soy milk, edamame, the least processed version of soy is beneficial. It's some of the junk food that's been processed that we want to stay away from.
Got it. Excellent. This is an interesting question. It looks like this woman's sister had a radical mastectomy in April of this year, and she's wondering what she can do or provide in the way of support. She's a warrior for sure and has done well, but I worry how it's impacted her psychologically. Do you guys have any suggestions among the three of you?
I do. I would say going for walks in nature together, long walks, and just having a social support for her is very meaningful. To know that she can call on you for a walk, or cooking a recipe together, making a soup that is just crazy filled with lots of different vegetables, or going to a farmer's market together, just doing things that are fun, something to de-stress, to make her laugh, play cards, play games, play words with friends, or something together online. One suggestion that is one of my favorites that one of my patients shared with me was her, and it was actually her mom, her and her mom would text each other before bed the 3 good things that happened in a day. So instead of keeping a journal, they would share it with each other. So it was just, it reframes looking for the positive during the day so that you have something great to text. So I kind of like that one. Does anybody else have suggestions?
One suggestion that I have is to give people coupons for assistance. So depending on what their stage of life is, a coupon to go shopping, a coupon to go for a walk, a coupon to, if they have young children, watch their kids for an afternoon so they can do whatever they want. And a coupon to go to the movies. And that way they know that you're serious, that you want to spend time with them and help them. And then you mentioned this person asked also about psychological effects. And so I would strongly recommend engaging in some of the either in-person or online support systems from the American Cancer Society or the cancer support community, because the old-fashioned in-person support group, those are still there. But I think one of the lessons that we've learned from the pandemic is that they're not always within reach for people who have a busy life. And so being able to connect to an online support or discussion group has been really valuable for many of our patients. And because it's easier to fit something into your life that you don't have to drive to. So those are some suggestions that I would put forth.
Those are great suggestions. And on the other side of that, do you have any words that you give your cancer patients about don't be afraid to accept help? The people around you who love you want to help you, and it does make people feel good to help each other. Is there anything you tell patients as they're sort of struggling along the way?
What I tell patients is to manage in. And I learned that phrase from somebody, it might have been on Facebook, so I'm sorry. But the idea being that at the time of a new cancer diagnosis, there are a lot of people who offer help. And that is, that is with the best of intentions, but sometimes it can almost be overwhelming to manage all the help and advice that people are offering you. And so what I tell people is to focus on themselves and their immediate, I'm sorry, got a cat photobombing me. Focus on their immediate family and really take care of just each other and their needs, and let everybody else kind of manage themselves. And so you manage inward and let the other people who might want to come and talk to you about your aunt who died, or the lady at church who died. Those are important stories, but that may not be what somebody who was recently diagnosed with breast cancer needs to hear. And so those are recommendations that I make.
Those are great. I think that's wonderful. Okay, so next question is for Dr. Nossoni. Is there anything that a person can do? I just have to stop for a second and say, like, animals and babies are my favorite part of video. It's like, I love the guests. Okay, so sweet. Which I would say they're also a good part of recovery. I would think having those pets and companions and your little fur babies can also be, at least for me, it always makes my day better. Okay, so Dr. Nossoni, is there anything a patient can do going into a surgery to help improve their recovery?
I think one of the things I personally do, I always have the patients bring their significant other or their daughter or someone who's the primary care provider in the immediate post-op days with them to the preoperative visit. So we can kind of have a discussion about what to expect and kind of like the timeline of what's going on. I think having information is the best way to prepare yourself for the surgery and the best way to recover. With regards to what are the specific things that you can do, I think being in the best shape possible, having the best diet prior to surgery, that I think Lisa probably could help with that. Some of the tips of how to kind of prepare yourself to be nutritionally in the best state possible. Obviously, any sort of I don't want to use about bad habits, but things like smoking and drinking, they all needs to obviously be stopped quite immediately in order to kind of prepare yourself for the best outcome and the best recovery. But I think having a family member or the main care provider in the immediate postoperative surgery come with you to that preoperative visit is very, very important because it provides it gives them an opportunity to ask questions about recovery as well.
Excellent, thank you. So we just have a couple more questions if you guys are okay staying on for just a few more minutes. If that works for you. Okay, perfect. So this question is about the aesthetic flap closure. Can a patient have reconstruction if they change their mind down the road after having that procedure?
Yes. Yes, we
Okay.
can work with them. We can again, it's such an individualized process for us that is so difficult to give a generic answer. But we can work with placing a tissue expander, recreating the inframammary fold. Again, that 3 basic principles that I talked about being the footprint, the conus, and the skin. We have to make sure we've worked to create that. And it also depends on the stage of the recovery and the type of surgery that they had, whether they have radiation or not. It's a very individualized process, but it's something that can be done in a delayed fashion, yes.
Great. It sounds like there are so many options to really help the patient make it their own.
Absolutely.
Great. And then I will pose this question to all 3 of you. I'm guessing Lisa will have something to say about it. So are there any products that you suggest patients avoid? We could talk about lotions or shampoos, deodorants, things like that. And I guess you could even expand it to food.
Yeah, I think reading ingredient labels is so very important. And we know that there are a lot of resources for clean ingredients, and I can provide that. One thing I would say is getting something that is as close to natural as possible, because our skin definitely does absorb, and we're exposed to so many different things. So it's important to pay attention to what's in the products. I know that for cosmetics, there are a lot of natural lines available now that they're not adding anything. It's just plant compounds. So making, choices that we just get rid of the products that are not going to serve us. When it comes to food and ingredients, those labels are very tricky. Natural flavors, artificial flavors, sweeteners, different words for, there's over 70 different words for sugar. So really looking at labels and seeing what the label provides. And if we can't pronounce the words or you don't have those type of ingredients in your cupboards, they're probably best to avoid. I think that concept of real food doesn't need a label is nice, that you can just assemble fresh cut ingredients without having to dive into the packages. And we have a lot of resources in our lifestyle medicine program. We go very deep into nutrition and give grocery shopping lists and recipes. So if anybody's interested, we have a lot of resources there for how to read labels and what to avoid. Definitely the saturated fats, the trans fats, we're really kind of honing in on what products bring us the most health. And if you think about things like an apple a day keeps the doctor away. Spinach, Popeye was strong to the finish because he ate his spinach. These have these old adages for a reason. They help our health. Blueberries for our memory and cognition. So just getting the different color in the rainbow and trying to avoid the processed foods as much as possible.
Okay, perfect.
If I add something very briefly, for when it comes to lotions and surgical scars and whatnot, we usually recommend patients to wait till the wound is essentially entirely healed and make sure you get the okay from the surgeon. I personally like water-based lotions as opposed to oil-based lotions, but that's kind of like a personal preference for the most part. But we have had good experience with water-based lotions. But make sure you kind of like, if you have a surgical incision, to talk to your individual surgeon to make sure it's okay to start using lotion and creams on the skin first.
Okay, perfect. Thank you for adding that in there. I think this last question is for Dr. Breslin, I would imagine. What is the probability to a reoccurrence after a lumpectomy?
So after lumpectomy with radiation, the likelihood of recurrence in the breast is around 5% or less. Now, that doesn't include the risk of recurrence elsewhere, because that's really determined by the type of cancer. But in general, the results from a lumpectomy followed by radiation, or a lumpectomy without radiation, are all associated with similar survival.
Okay, fantastic. There are a couple questions here. I apologize. I lied. It wasn't the last question, but there are a couple questions asking about if there are any prosthetics that you recommend to patients. Is that an option as well?
Yeah, that's a really good question, and we didn't mention that. But in addition to covering breast reconstruction, the Women's Health Act also mandates that insurance covers post-mastectomy products such as bras and breast forms, and those can be obtained either through the In-Spirit salons at our hospital or through prosthetic providers such as a physical therapy or prosthetics provider, and you just need a prescription from your physician, and that's, you get a certain number of bras and prostheses each year.
Excellent. That sounds maybe like a nice way for a woman to kind of have a moment to think about what she wants to do and how she kind of wants to move forward. I'm sure it's a lot on a patient's mind, I'm sure, as they're going through the whole process. So that is the end of the questions. If you have anything else you'd like to add, feel free.
There was another question here that I just wanted to touch on, which was, why would women decide to remove both breasts when only one breast is affected? And that's a really good question, and it touches on multiple domains. There are some women who are at high risk for breast cancer because they have a mutation in one of the breast cancer associated genes. So they might choose to have bilateral mastectomies, either prophylactically or preventatively, or as a part of breast cancer surgery. There are women who have make a decision that they prefer to have bilateral mastectomies, and that's a personal decision. Some women decide that they just don't want to do screening anymore, although the medical evidence doesn't necessarily support removing a healthy breast in someone who's otherwise not at high risk. Some women still choose it, and I support my patients who choose to have bilateral mastectomies in some situations and not in others.
Okay, perfect. Thank you for adding that in there. I appreciate that. Okay, well, thank you, all three of you, for taking the time to present this evening, and you went over 30 minutes, so we really appreciate you taking the time to answer all these questions. I will include your contact information for all of you in the follow-up email. So if you are interested in reaching out and meeting these providers in person, then you absolutely can do that. So I will share that, as well as some of the other resources that all of you have talked about or presented about in your slideshows. So thank you again so much. We appreciate you, and be well.